Good afternoon, everyone, and welcome back. We're happy to have you with us. We will start the webinar in just a few minutes here. But while we are waiting, we would love to invite you to take the pre-test. You can click on that little QR code that you see right there. And we'll also put the link in the chat box as well. And you can do it from there too. And I'm going to have one of my co-hosts copy and paste it into the chat box because I can't do it from where I am here. And so the pre-test, we do have a little special gift, and I want to emphasize that to be eligible for the gift, let me have you go back. Back. Sorry. To be eligible for the gift, you do need to complete both the pre-test and the post-test, and you have to be one of the first 50 people who receive the highest score. So the gift is not guaranteed to everyone. You have to complete both the pre and post-test and receive the highest scores. It's completely confidential. We know that you are not going to have all the answers, know all the answers to the questions. We don't expect you to at this point, but at the end of the webinar, we will have you retake the test, and we know that your responses will, you'll have more correct responses at that point, or we hope you will. And this will help the people who have generously funded this program and this webinar series know that the information that we were presenting to you did indeed increase your knowledge and your skills. So we'll leave this up here for just another minute as people are coming on, as I see people are still coming in. So again, please, scan the QR code with your little handy smartphone there and take the test while we're waiting. We're going to give you a couple minutes to do this. I have about 3 minutes past the hour. And we will start in just a couple of minutes. We have people to my co-hosts that are asking for the link in the chat box. If somebody can copy and paste it, because I can't get to it from where I am.
I can't. That's how I move the screen.
All right.
I can't get to it either.
Okay, let me see what I can do here. Hold on. We'll get it up there for you. I am having trouble getting it too, and I don't know why that is. Oh, I know why. Okay, I'm putting it in the chat box now. So it's in the chat box. So I'm going to give just maybe one more minute since we just got that in there, and then we will advance to the first slide, Kathy. Again, welcome everyone. We're just giving time for people to complete the pre-test. We're going to ask you to take it again at the end of the webinar. We know you won't have all the answers at this point. That's perfectly okay. Just answer to the best of your ability. And this is to help our funders learn that the knowledge, the information that we are presenting to you indeed was helpful to you and increased your knowledge. We do have a question. Will the recording be available to attendees afterwards? Yes, indeed it will. It will be posted on the One Caregiver Resource website, and Lori Resnick, who will be speaking to you in just a minute, will tell you how to access that. We will also someone said we just need a pre-test to log in. That should not be correct. So I will work on that in just a second. Lori Resnick will tell you about how to access the recording on their website in just a minute. We will also send the link out to everyone who registered for the webinar today. So with that, I'm going to move forward here so I can get that link into the chat box and just say, welcome everyone. I am going to turn this over, I believe. Oh, let me go to the next slide. We've got a couple housekeeping things quickly. Everybody's muted automatically by default. We are recording it as the questioner just asked, and you will have access to that in a couple of different ways, which Lori will tell you about. If you do have questions for our panelists, and these are questions about the content of the workshop, not technical questions, but questions about the actual content of the workshop, please put them in our Q&A box that you see at the bottom of your screen. At any time, we will be taking questions at the end of the webinar, but don't feel you have to hold your questions till then. Put them in, type them in just as soon as they pop into your head, and we will be answering them at the end. Next slide. And so, Lori, I am going to turn it over to you, and I am going to try and get that link up for people. And take it away, Lori.
Okay. Welcome, everybody. I'm so glad you're here. My name is Lori Resnick, and I am the Director of Special Grants at ONEgeneration. And I'd like to welcome everyone to our sixth and final webinar of the series, Creating a Physical and Sensory Dementia-Friendly Environment for Adults with IDD. This webinar has been graciously sponsored through a grant from the UniHealth Foundation, and the series has been extremely successful in that we have presented to over 2,000 attendees. This shows the importance of this education on specific needs of adults with IDD and Alzheimer's disease and related dementia, and our hope is to build on this curriculum in the future. I also want to acknowledge that our success could not have been possible without our amazing partners and colleagues at the NTG and our skilled ASL interpreters. Next slide, please. Before I introduce our presenters from the NTG, I would like to tell all of you about a comprehensive resource for adults with IDD, their caregivers, and professionals. ONEgeneration has launched a site, the One Caregiver Resource Center. I did put the link in the chat. It is a centralized platform to support caregivers and adults with intellectual and developmental disabilities who may be at risk of or living with Alzheimer's disease and related dementia. There's over 200 resources on categories that include healthy aging, what is dementia, dementia in adults with IDD, effective communication about dementia, advanced planning, self-care and respite for caregivers, research and clinical trials, and an archived educational training page where recordings of all of this series, all 6 of them, and many more recordings will be housed. Our next slide, please. Without further ado, I would like to introduce our presenters. Dr. Kathleen Bishop has over 40 years experience in the field of developmental disabilities and over 25 years as a gerontologist with a specialty in aging with developmental disabilities. She has a bachelor's and a master's in special education and a PhD from Syracuse University in aging with disabilities. Dr. Bishop works as a consultant for many organizations in the aging and IDD networks to assist with program and support planning, as well as teaches at Utica College online courses on aging with disabilities. She is retired from the University of Rochester School and the State of New York Office for People with Developmental Disabilities. Dr. Bishop is the co-chair of the NTG Group Education and Training Committee, the vice president for the NTG, co-chair of the advisory board, and a member of the executive board. She's been an active member of the NTG since its inception. Dr. Bishop has also been presenting a 2-day NTG Dementia Capable Care for Adults with IDD and Dementia Foundational Training with a 3rd day of a Train the Trainer. In this capacity, she's had the opportunity to train over 3,000 attendees in the 2-day training and over 800 on the 3rd day of the Train the Trainer training. She is also a published author. The book is called the Woman of Wisdom series under the pen name Mary Kathleen McKenna, which is available on Amazon.com. Our second presenter, Catherine Peers. She is the co-vice president of the National Task Group on Intellectual Disabilities and Dementia Practices and co-chair of the NTG's Training and Education Committee. Catherine is a nationally recognized expert on dementia who trains and consults with families, healthcare, and long-term care professionals and facilities and disability service providers. She specializes in the non-pharmacological management of the challenging behaviors that occur with dementia. Personally and professionally involved in the field of dementia for over 30 years, her interest in dementia began in 1981 when her father was diagnosed with early onset Alzheimer's disease at the age of 56. Catherine was director of policy and programs for the Alzheimer's Association Maine chapter for 15 years. She also served as a registered lobbyist for the chapter and led the effort to make Maine one of the first states in the country to require special care unit disclosure for nursing homes, mandated training on dementia for nursing home staff, and a silver alert to mobilize law enforcement and the public when a person with dementia wanders and goes missing. In 2011, Catherine started her own training and consulting company, Dementia Care Strategies. Catherine lives in Aiken, South Carolina. I would like to welcome both of our presenters today. We are very grateful to have them and also to have them for this entire series.
Thanks very much, Lori. You can move to the next slide, Kathy. I'm going to get us started off here. We do have the traditional medical disclaimer that says, don't disregard professional medical advice or delay seeking medical treatment. We don't endorse or recommend any specific tests, physicians, procedures, or whatever. The information that we are presenting here is educational in nature only. We take no responsibility or liability for use or misuse of the information. This is for information purposes only. Thank you. We'll go to the next slide. And these are the objectives today. We're going to learn about sensory processing and how it's affected by Alzheimer's disease and other related dementias. And we're going to give you some practical strategies for, dealing with sensory issues as they arise in the environment. So let's go to the next slide. And I'm going to start us off with talking about the brain and how the disease process affects the brain and the different parts of the brain that are involved in sensory processing, and kind of give you a little sense of that kind of general background information. And then Kathy Bishop is going to come on and really give you much more in depth with very practical strategies and tips that you can implement in your home or organization. So next slide. So, we take our brains so for granted. Our brain is in charge of every single thing we do in the course of our day. We wouldn't be able to do anything without it. And we don't oftentimes step back and think, how important this function is. We just take it so for granted until something goes wrong with the brain. And today we're here talking about Alzheimer's disease and related dementias. And those are diseases of the brain. It's unfortunate there's a stigma associated with them because this happens to be a disease of the brain, but it's no different than a disease that affects any other organ in the body, such as your heart, your lungs, your kidneys. It's a disease process. And in this instance, it's the brain. And because it is the brain and because of the important functions the brain provides for us, we oftentimes see that damage from the disease process being displayed as behaviors. And it's hard to understand that because the person looks the same on the outside. We don't see that damage going on the inside. And so we wonder why they do the things we do. And so Kathy and I are hoping to explain to you today a little bit about why some of the behaviors you see in dementia happen, and specifically behaviors that are brought about because of sensory processing issues. Kathy and I could both do a college semester on this course. So what we have the time to, talk to you about today is going to be just the Reader's Digest version. But we hope we pique your interest enough that you'll want to look into it more on your own. And we're always happy to suggest resources for you if you'd like more information. But we've got to think about the brain and, every single thing we do. Think about what you did this morning. You got up, you got dressed, you knew you had to go somewhere. You maybe made yourself a cup of coffee. You maybe made some breakfast. You got to work. You've been working. You're multitasking. You've been talking with people. They've been hearing your voice. All of that, even my moving my hands as I am right now, that's my brain letting me do that. I'm not sitting here thinking, move right arm up, move to left. Not like robots where, it just happens. That's our brain. Next slide, please. When there's damage to the brain and the parts of the brain that control all of our motor functions, our language processing functions, we see, these changes that we think of as associated with behaviors of dementia. So just very quickly, I want to give you a real quick, tiny little bit of information on how the brain makes those signals happen. And what you see here is a nerve cell. And you may remember your basic anatomy from high school, where we have these nerve cells and we have billions and billions and billions of nerve cells in our brain. And all of those brain cells have a little tiny space in between them called a synapse. That's that little circle that you see there, that little larger circle image. And there's a little space between those synapses. And there are these chemicals called neurotransmitters that have to jump between one brain cell and the other brain cell for the brain cells to communicate. And if those little synapses, those little gaps aren't functioning properly, then those brain signals aren't getting from one nerve cell to the other. And if those nerve cells are not communicating with each other, then we can't do a lot of the things we do. And of course, it depends on the part of the brain where this damage is occurring. Next slide, please. This is a nerve cell that has been damaged from Alzheimer's disease. And you see those little fingers that are coming out from that nerve cell. And at the end, you see those green blobs. You probably heard the talk of the plaques and tangles with Alzheimer's disease. And those are the plaques and the tangles. And you can see that because of this damage that's occurred on the end of the nerve cell, those signals can no longer be transmitted to the adjacent nerve cell. Next slide, please. And so here's just another way of looking at it. On the left, you see those healthy nerve cells. They look like kind of roots of a tree almost. And on the right, you see what that damage looks like, and those plaques and tangles. And you can think of those plaques almost like the plaque that is on our teeth, and we have to go to the dentist periodically. It's kind of a sticky, substance. And that plaque causes those nerve cells to die. And when those nerve cells die, not only can they no longer transmit signals to each other, but the brain actually shrinks. Next slide, please. By the time you get to the very end stages of Alzheimer's disease specifically, the brain actually has shrunk by as much as 30%. I don't know if you knew that or not. And this damage doesn't just happen immediately. It comes on anywhere from 10 to 20 years before enough damage occurs in the brain that we see those outward symptoms. And of course, it depends, if you go back to remembering your anatomy from high school, on what part of the brain the damage is occurring in at any given point in time. If you think about the brain, and you see on this slide, there are very different, we have lobes of the brain, and each part of the brain controls a different function. Today, we're talking about sensory processing. So what I have here for you is an illustration showing the parts of the brain and where the different sensory processing functions are located. So your sense of smell, hearing, touch, taste, vision, and so forth are all controlled by different parts of the brain. And if you think of those brain cells that are now damaged and not communicating, you can start to understand why some of the behaviors that you see, particularly as they relate to sensory issues, may arise. Next slide, please. So when those senses no longer function normally because of that damage that's occurring to the brain cells, people have an altered perception of everything they see, everything they hear, even what they taste and smell, or even what they feel for sensations on their skin. And this can explain a lot of the behaviors that you see in dementia. So let me give you some examples of how that might play out. We talk a lot about people being combative during bathing. Well, sometimes that could be because of a vision problem. If it's a white bathtub or a white shower, and Kathy Bishop will probably show you some pictures maybe later of this. I haven't looked at her presentation, so she may or may not. But envision a white tub or a white shower. For people who have vision issues, sensory processing issues, that lack of contrast, it may look like you're trying to push them or get them to go into this huge gaping hole or a cavern, because there's not enough color contrast. Sometimes you could put a red bath mat in the bottom to set up more color contrast. Interestingly, we've heard from lots of people who have dementia who are still able to articulate and talk about what they're feeling, that the sensation of water on their body from the shower head feels like they're being pricked by thousands of tiny needles. And if you and I were felt we were being pricked by thousands of tiny needles, we'd want to get the heck out of that situation. So sometimes what appears to be combative, because remember, people's verbal processing skills are damaged. They can't necessarily tell us what's bothering them. So that behavior comes out, so that communication is a behavior. So you're going to see, I'm going to say at the end, all behavior is communication. That's very true. So that person who seems combative, trying to get out of the shower, they can't tell you, oh my gosh, it feels like I'm being pricked all over. They just want to get out, and the only way they can do it is to try and push past you and get out. That can be interpreted as being combative when it's really physical discomfort. Even sometimes the temperature of the water can feel too hot or too cold. And so it may feel comfortable to us, but to that person with dementia, it may be too hot or too cold. And again, none of us would want to get into a tub or a shower if it felt uncomfortably cold or hot. Sometimes people don't want to leave their home, and we wonder why that is. Well, think about sitting in the front seat of a car and being driven somewhere, and there are other cars coming towards you. Again, visual processing changes. That sensation of the cars coming towards you, you and I, because we don't have that damage in our brain, we understand what it is. But for that person with dementia, that image that their brain is giving them may look distorted. And it may just look like things coming directly at them, and that could be very scary. And then the general population, there have been instances where the person riding in the front seat has actually reached over and grabbed the steering wheel because it felt like there was a car coming directly at them, and they've had an accident. Even overstimulation. Think about going to a crowded store or a restaurant or maybe a sporting event. And it may have been something the person always enjoyed before, but again, now because of that disease process and the damage in the brain, their vision is distorted, how they see things, how they hear things is distorted. That cheering crowd could just sound like a horrible, thundering, random noise. The movement of the crowd or the sporting event or whatever it is can just look like random movements, just very distorted looking in their eyes. That would be very scary. And so we do see people with dementia oftentimes just not wanting to leave home because that's a place of safety and comfort and it's familiar to them and they understand how to live in that environment. But leaving that environment can be very off-putting to them. And oftentimes the reason people don't want to leave home is because of all the sensory processing issues they have when they're outside of that environment. Next slide. Sometimes we hear of people with dementia who don't eat, and people will say, well, I guess they're not hungry anymore, they're not eating. Or people will tell us that, the individual they're caring for now only likes sweet things. They don't want to eat the foods they used to like. Now they just want to eat sweets. And that's because of the changes to the part of the brain where we have taste. And so we have been told by people who have dementia, again, and can still tell us, articulate these things they experience, that to them, at some point, food starts to taste very bitter. Or a woman one day said food tasted like bleach. And somebody else has said cardboard. I think it varies for every individual. But again, if what we were putting into our mouth to eat, food may be perfectly fine, but we're perceiving it as tasting very differently, we probably wouldn't want to eat either. But once again, because of the damage to our language skills from this disease, we can't say to the person who's providing care for us, that food doesn't taste right to me. We can't tell them that. So what do? Well, we just don't eat. Sometimes it's a vision problem. Think of a white plate with mashed potatoes, boiled chicken, and cauliflower on it. There's no color contrast. That person with dementia, just like getting into the white shower or the white bathtub, doesn't have any color contrast and may feel that they're being asked to enter this, huge cavernous space that they can't really see. The white food on a white plate, there's no color contrast. They may not even literally see that there's food on their plate. So one idea is a bright red plate to increase color contrast. Dehydration even, we talk about people, very, very common, people with ID generally, and also people with dementia become dehydrated because they don't drink enough. Sometimes the reason they don't drink enough is because they've lost the ability to interpret the feelings of thirst. And so they might be thirsty, but they don't, understand that sensation that you and I would all interpret as being thirsty. And you and I can all get up and go to the refrigerator or go wherever and get something to drink. The person with ID, because of their dementia, may not be able to do that. They may not recognize the room they should go to do that. They may not remember how to turn on the water faucet. They may not be able to remember where glasses are kept. So it becomes very difficult for them. So as caregivers, we need to make sure we're monitoring people's fluid intake. And again, it doesn't have to be just plain water. I am one who's not a huge fan of plain water. And if I do have water, I like it with ice cubes and a straw. I'm very particular about it. And So, it doesn't have to be just plain water, any liquid, soup, juice, watermelon is full of water, cucumbers are filled with water, ice pops, anything that is in a liquid form when melted will do. Agitation and anxiousness. Excuse me. Sometimes that's a result of some of these sensory processing difficulties. Oftentimes hearing people, because of that damage in the brain, they will forget the meaning of common sounds. So a phone ringing, maybe not so much anymore now that we have our cell phones and they vibrate in our pockets, but that sound of a ringing phone, that traditional sound of a ringing phone, you and I would know, oh, the phone is ringing. The person with dementia may not recognize that. They'll hear a noise, but it will just sound like a random noise. And they won't associate it with, oh, I need to go pick up the phone. Smoke alarms, safety issue. Sadly, there have been instances where people with dementia who have been living alone, died in fires because something in the house caught fire. Sometimes something they did inadvertently, leaving something on the stove, unfortunately, but the house caught fire. They didn't recognize the smell of the smoke. They didn't recognize the sound of the smoke detector going off, meaning there was an emergency and they should get out. So safety issues here, particularly around fire, is something you need to be concerned with. TVs. People with dementia, because of that damage, may not understand any longer the meaning attached to the TV show or the radio. They may think that what they're watching on the TV is actually happening in front of them. And if it's science fiction, I think of zombie movies. TV news can be filled sometimes with some very graphic scenes. Sometimes people will misinterpret what they see on the TV and think it's really happening to them. And so if you see people getting agitated and there's a TV on the room, they may be reacting to what's on the television or radio as well. Sometimes people will hear something on TV or a radio in another room and they'll think there are people in the house. They don't realize it's the TV. They misinterpret that to think that there are actually people in the house and maybe there shouldn't be. Interpreting facial expressions and body language. Studies have been done that show people with dementia will misinterpret even a very benign facial expression as being threatening. And even body language. When we talk about communicating with people, only 7% of communication is the spoken word. 93% of communication is your tone of voice and your body language. And so people with dementia can misinterpret not only things you say, but your facial expression and your body language, and it can be threatening to them sometimes. And that can account for anxiousness and agitation and sometimes combativeness. And pain, people with dementia oftentimes lose the ability to interpret body sensations that you and I would know were pain. And that can result in agitation and anxiousness. So one of the important things to realize is if you see someone and they are anxious or agitated, first and foremost, always rule out that they, aren't sick or in some sort of pain, because they're not going to be able to tell you that they're in pain. It's going to come out as a behavior. Next slide. Incontinence, sometimes that's the result of losing the sensation of the fact that your bladder is full. We all know what that feels like. The person with dementia may not recognize that sensation anymore, so they don't get up to go to the bathroom because they don't interpret that sensation properly. Sometimes they may not even be able to find the bathroom. It could be a vision processing thing. Think of a white hallway with bedroom doors and a bathroom door, but all those doors are white. We go back to that lack of contrast again. They may not be able to find their way to the bathroom. Sometimes we hear people referred to as being stubborn or non-compliant or oppositional. Sometimes that's just a result of the fact that the words they hear in their brain, it takes them longer to process the meaning of those words. So when we deal with people with dementia, we have to slow our speech down, use simple sentences. It's going to take them longer to process the language that they hear. Sometimes people with dementia remove their clothes and we think, oh, they're, suddenly have become exhibitionists, they're exposing themselves. Well, maybe they're just too hot. Or maybe their clothes are scratchy and uncomfortable or itchy. And because they can't tell us, because of the loss of communication skills that occur with the disease, they're simply going to, do what they have to do to relieve the discomfort. And that may be taking off their clothes. Not anything sexual or weird. They're just trying to relieve that discomfort in the only way they know how. And hallucinations and delusions. Oftentimes, this is just a misinterpretation of things they see or things they hear. Kathy's going to talk more about this. But, my dad used to, particularly in the fall, it's dark outside in the fall, it gets dark earlier in the day. And so we turn the lights on in the house and he would look out the window and see his own reflection. But he didn't recognize his reflection in the window. He thought it was someone standing outside. And sometimes that guy outside was friendly and they'd wave at each other and my dad would laugh and smile. But sometimes that guy outside didn't look quite so friendly. And then my dad would become very agitated. Fortunately, it didn't take us too many times of this happening before we realized that he was seeing his reflection and that was upsetting him. So the answer to that problem wasn't to get an antipsychotic medication. The answer to that problem was to close the curtains before it got dark outside. He also used to go in the bathroom sometimes and see his reflection in the mirror and no longer recognized his own reflection in the mirror and would think it was somebody else in the bathroom. And of course, you and I, if we were to go into the bathroom and think somebody else was in there, most of the time we'd probably walk back out, which is what he did. So again, these are misinterpreting things that the sensory processing damage that's occurring. For that instance, the solution was to cover up the mirrors. Sometimes people will look at a picture, like a family picture, and they think those people are actually there. They don't realize they're looking at a picture. Next slide. So when you're faced with a new behavior, what I want you to do is just observe and evaluate, take a step back, literally and figuratively, and think about how that person with dementia might be perceiving, might be seeing their environment, seeing the situation. Remember, behavior is a form of communication for people with dementia. All behavior, and I mean that very literally, all behavior has meaning. Almost every behavior that you'll see exhibited by a person with dementia, if we kind of do a little bit of digging and become a detective, we can figure out what's causing that behavior. And if we can figure out what's triggering the behavior, we can usually find ways to manage it or to minimize the likelihood that it will occur again in the future. So with that, I'm going to turn it over to Kathy because she's got a lot more information that's going to illustrate some of these points I just talked about for you.
And Catherine, I do have, I have one question that came through. I'll give it to you and then I will also respond as I do because it's directly related to what I'll be presenting. So the question is, are nerve endings in nerves outside the brain also damaged as a result of Alzheimer's disease?
If I interpret your question correctly, yes, we have nerves all over our body. But what I'm talking about specifically is the nerve cells in the brain that transmit, those signals back and forth, those synapses. So I am not aware that the actual nerve cells, like you had, if you stub your toe, for instance, it hurts. That actually is all processed by your brain. I'm giving you a convoluted answer here. But if you stub your toe, you feel the pain in your toe, but you're feeling that pain in your toe because of the signals that are going back and forth in your brain. Sometimes we talk about people and I've heard this about people with Down syndrome as well, but we talk about people with dementia as not feeling pain any longer or having a higher pain threshold. And it isn't really that they don't feel pain or that they have a higher pain threshold. their brain just interprets it differently than ours, and so it may look like they're not feeling it, or they don't feel it as at the same level than we would. I hope that kind of answers your question.
Yeah, that was the direction I was going as well, and I'll in more detail as we go through the next part, as I'm presenting. In terms of the plaquing and tangles, they directly damage the brain. And there's not, as far as we've seen in any study, not a direct from those to the other body parts, the other nerve endings. However, and I'll do this in more detail, the brain requires hydration, and Catherine has just talked about how people may stop drinking and not recognize thirst. So for those synapses, those connections to work, if the person is dehydrated, that means the brain will not function, and direct damage from AD, from the plaquing and tangles, can exacerbate that. Additionally, the brain requires movement. And so with movement, that is helping, at least for optimal functioning, requires movement. And so the secondary conditions, the secondary risk factors may be causing damage to the nerves and the nerve endings, for example, from lack of movement. And so muscles break down, for example. We have no evidence direct from the plaque and tangles, but there are a lot of secondary conditions that occur. So Catherine, does that answer also, you think, help and make sense? Right. So let's talk about, and I'm Kathy Bishop, just to remind you. Let's talk about the difference between sensory impairments and sensory processing disorder. The sensory processing disorders or challenges, many of them are a direct result. Additionally, there may have been some earlier in life, but are a direct result of disease process, which is that pathology of the plaquing and tangles that Catherine has talked about in great detail. So my part of the presentation is to really look at understanding the difference between sensory impairments and sensory processing, and how that can impact people's functioning, as well prior to Alzheimer's disease, and how the disease itself and the plaquing entanglements will cause further damage to the brain and interrupt the process, making it more difficult for a person to function. It is essential a differential diagnosis is conducted for everyone who's being diagnosed with Alzheimer's disease, and that differential diagnosis, which is differentiating between two or more conditions that share similar signs or symptoms, and ruling those out as the cause. Since we know that Alzheimer's disease is considered an irreversible disease at this point, from what we understand from the research that has been done so far, we can maintain and help promote quality of functioning in life as long as possible, but we can't reverse the damage that's been done. However, parallel with, at the same time, and the older people get, the higher the risk for those secondary conditions. Alzheimer's disease doesn't stop those impairments, the processing challenges, and in fact may speed it up because people reduce movement, are less engaged with the environment and with others around. But there may be interventions that can be provided. So it is always essential to think about sensory impairments and sensory processing, and to know the person's baseline functioning and sensory needs earlier in life. So when there is a disease process, we can make sure we're setting up a physical environment as much as possible. Some of the diagnostic issues for people with IDD: communication challenges, comparisons for loss not as severe if there's a pre-existing cognitive impairment. Healthcare providers who do not know the person may assume the functioning of the person that may be the baseline functioning. the baseline personality, baseline behaviors may have been pre-existing, but the healthcare provider may not know that and may automatically diagnose people with Alzheimer's disease or related dementia. Diagnostic overshadowing, loss and symptoms being attributed to the pre-existing conditions, in particular a form of IDD, difficulty using standardized tests, fear of further labeling, anxiety over the future, inability to self-report, and increased sensitivity to unfamiliar environments. I'm just trying to give you some of this background. Physical environments must always be designed in terms of a balance of the challenge and ease of use, but also some challenging. And this is another visual of the brain. You can see on the left, the normal, and on the right, you can see as a result of Alzheimer's type dementia. You can see there's a great shrinkage of the brain, meaning there's certainly less mass to the brain. There's also less connection points. And then we also have the pathology as well. For people with Down syndrome and Alzheimer's disease, there is what we call an overexpression of trisomy 21. People with Down syndrome, every cell of their body, or for the highest percentage of people with Down syndrome, every cell of their body has 3 chromosome 21s genes. For the rest of us without Down syndrome, we have two chromosomes 21s in every cell of our body. In terms of what we're talking about today, the APP protein, which is one of the major substances, underlying substances of the plaquing and neurofibril entanglements that Catherine showed you in her slides. For people with Down syndrome, there's from the beginning of life an overproduction of it and overexpression. And so the higher amount of plaquing, higher amount of the APP in the body results in plaquing, and tangles can be much earlier in life. And so that's why there is a higher risk for this disease. Also, this will impact sensory processing capacity as well as sensory impairments. So these are sensory processing disorders. The sensory processing function is in the brain. And I'm not going to talk about all the different disorders, but understand the most amount of study of sensory processing disorders has been on children, and in particular children with a type of autism. There have not been a lot of studies, and there are not even really good assessment tools at this point for adults. Most people who are older today at risk for Alzheimer's disease and related dementia have never had an assessment or the consideration of sensory processing disorders. The current research and the current thought is that there are probably many people with IDD who have sensory processing disorders early in life that may have been labeled as behaviors, non-compliance, have other labels to them, or just assumed that diagnostic overshadowing, assumed to be part of the IDD, the developmental disability. So understand many people enter into this disease already with sensory processing disorders, and then the disease will make them worse. The sensory processing, again, as I said, is in the brain. And you can see here where sensory processing occurs, and you can see where the disorder can, in particular, the red parts of the brain here, are the areas where the sensory processing process is being disrupted. You can see for people with autism, again, the only place there has been a massive study is for people with autism and different types of autism. you can see that there are higher amounts of sensory processing disorders that have been observed and measured in the brain. So let's talk a little bit further on what Catherine has done an excellent job of discussing in terms of brain damage. So in particular, the effect of Alzheimer's disease on the brain is hippocampus. Now understand, sensory impairments occur in the cells in the external part of the body that gather this sensory information in the environment. That sensory information is then is communicated, is sent to the brain in the brain through a number of complex process, be able to send it to the parts of the brain for processing. The hippocampus is the first part of the brain that is most usually affected by the plaquing and entanglements, and it's not exact. The Alzheimer's Association will say, once you've seen one person with Alzheimer's disease, you've seen one person with Alzheimer's disease. And that's probably true. Probably every brain with the plaquing and tangles looks different. And there will not be like it's always step 1, step 2, or step 3. But current research shows that the hippocampus is the first part of the brain that usually is damaged by the plaquing and entanglements. If you think of the hippocampus as kind of the conductor of the brain, and so if you think of an orchestra conductor that is conducting thousands and thousands of musicians in the orchestra, and the responsibility of sending that information and making sure when they're conducting the right information is going to those thousands and thousands of parts of the brain that need to have the information, but now there's damage that happens. And so the conductor, which is the only way we connect ourselves to what is not us, outside us, to the environment, to others, to the universe, to everything that's in the environment. Now that conductor that's taking that information that we hope hasn't been damaged even before it gets to the brain, now trying to send it to the parts of the brain. With the continuing plaquing entanglements, it's not going to be able to send to the other parts of the brain. There's going to be places it's sent to the wrong place. Pathways may already have been destroyed. And for many, many reasons, the first that is often affected by this damage at the hippocampus level is the capacity of the hippocampus to send to the parts of the brain for short-term memory. Short-term memory, what you learned today, yesterday, the day before, is lost first in this disease. And it's because of this plaquing and entanglement. Sensory processing is the first that is impacted. So if people did not have major sensory processing challenges earlier in life, it means that now this plaquing is going to start the sensory processing. But remember what I said, people with IDD may have started even sooner in life. The hippocampus is responsible for episodic, in other words, routine binding of events, information, strategies, and behaviors. This episodic binding makes it possible to perform functions that are functions of habit that we do every day, that we don't have to think about intensely, because the hippocampus sends it to the parts of the brain that do the work for you to be able to automatically do things. If you've ever found yourself driving or traveling someplace, and sometimes maybe you've had practice meditating, or maybe you're just drifting off thinking about the day ahead of you, and you totally forget to concentrate on the route you're taking. You find you've taken a wrong turn. That for the brain means that in episodic binding, there will be routes that are usually done in those things that are habits and routines And now it's being disrupted. They're no longer habits, and now mistakes are being made, and you have to stop and take more time, which takes more energy to do those things that used to be routine and habit. By the way, especially in this disease, if something like COVID happens, which disrupted all of our routines and habits in different ways, that will start also interfering with episodic binding. But now if someone has a disease process, now there's even more likelihood of interference with this, meaning people cannot perform functions they've been able to perform all their life. Damage can prevent sporadically this binding of information to be able to function. So it may be able to brush their teeth in the morning, but not brush their teeth in the evening, or even remember what brushing their teeth is all about. May be able to comb their hair or wash their hair in the morning, but not do it at night. And so it's not like it's something you can adjust to, because tomorrow there may be damage in a different way, the interruption of the episodic bindings. This is something really important to think about, that for people with Alzheimer's disease, you are going to have to help them through maintaining habit and routine. And it's essential that you stick to habit and routine as much as possible. Also, the hippocampus is responsible for contextual processing, being able to be in the context of the moment, to be placed in the physical environment, because what might be appropriate being in a classroom is not necessarily what's appropriate for being out in the playground. Or being in a classroom where you're supposed to be quiet is one context that is different than what you would do at a sports event where you're in the audience cheering on the team. And so the understanding of context, of where you are, what's expected, how you're supposed to function in this context is disrupted by the damage to the hippocampus. And I will talk in a little detail, that understand that every single slide I'm doing can be a semester-long course, let alone both of what Catherine and I have done. So I'm trying to give you the base to help you understand why it is not behavior. There is meaning to why people can't function, meaning to why they do things. And I'm trying to give you an understanding of how, what areas are being damage that especially disrupt the ability of the brain to process. There's also, we've seen in research on rats, there's a reorganization of the cellular code. That means that reorganization, and that reorganization makes it possible for rats to be able to function in unfamiliar environments. Now, remember, with Alzheimer's disease, every environment, including familiar environments, becomes unfamiliar, becomes challenging, novel. In rats, at least in the study, we've seen that the disease and in this plaquing and tangles actually disrupts the ability of the brain and the hippocampus in particular to reorganize that code to be able to respond in unfamiliar settings. The hypothalamus also works with the hippocampus to determine motivational state. What sensory stimuli in the outside environment to pay attention to and what to ignore. As you learn more about this, to me, it's always amazing that people are able to function and continue to function in any way throughout the course of this disease. Or for people who've had sensory processing disorders, especially undetected, it's amazing that we have not recognized that. As I study this, I see some sensory challenges that I have, and I suspect I have some sensory processing, if not disorder, at least challenges to it, but it's nothing we paid attention to in the past. And so we've learned ways to adapt when our brain was relatively healthy. Now we have next the central cortex, which is the gray matter of the brain. This is the most highly developed part of the brain. This is where we get left and right differentiation. And if you think about some of us are right-handed, some of us are left-handed. Our brains actually have a left side and a right side. And if we're right-handed, we are developing the left side of the brain in more detail earlier in life. The left side of the right side of the brain is being less developed, and there are different functions in the sides of the brain, but now those different functions is really confused with the damage that happens to the central cortex, which is the most highly developed part of the brain. We do find something like touch, which is really interesting, is found in both the left and right lobes, which means even with damage, the sense of touch may be one of the touches you can use to help people move through space and to be able to perform former activities of daily living, former functions that they have performed. The central cortex is also where the occipital lobe for vision. Sorry, I know I didn't pronounce that right. The temporal lobe for memory, emotions, hearing, and languages. Spatial working material memory is here. That spatial is remembering the spaces you're in. We know that studies have shown us over and over the senses that seem to have been most disrupted by this plaquing entanglements fairly early in this disease is the proprioceptor and vestibular senses we'll talk about in a minute. These are the senses we use for movement and location in space. The central cortex has the part of people being able to have kind of a visual memory in the brain, a spatial memory that helps them locate in space and know how to locate in space. That's now being damaged. Access and corrects behavioral responses using past experiences. So in childhood, you may have thrown a temper tantrum. You may have even become aggressive towards a parent or a sibling. That was corrected. And as a young adult, an adult, and an older adult, your brain still has the memory of that correction and will not become assaultive, bite someone, will not throw a screaming temper tantrum. However, if the central cortex is not working, those past experiences have been forgotten, no longer to get to the part of the brain to have that memory. And so you might find a 70-year-old, 60-year-old who has this disease, who now is going to past behaviors that may have not been exhibited for years and years. For people with IDD, the correction and the memory may have been going back to the 20s and 30s, but no longer connect to that and now be resorting to behaviors that they had learned were not appropriate in the situations. And so while that's why you'll see inappropriate behaviors, but understand it's the damage of the brain that is bringing back past behaviors that they have not exhibited in years. And it's important to figure out and know who the person has been as much as possible and know what worked when they're younger and how you can help eliminate a behavior that's dangerous to self and others. Reception and sensory processing, the central cortex is one of the central places for that. The damage of that means that there will be difficulty understanding the sensory information in the environment. Similar to what Catherine showed a few minutes ago, and the most important thing to understand is hydration is essential for the connections, even before the connections are damaged. If the person is not properly hydrated, the brain cannot send the information through those connections. And so hydration is essential for the brain to function. Severe dehydration can look like a type of dementia, which is why it always needs to be ruled out. And especially during the disease itself, because the person may be exhibiting more loss than from the damage from the Alzheimer's disease because they need to be hydrated. They are severely dehydrated, do not understand the sense of thirst, may not be able to respond to sensory stimuli, and also then may be afraid to move throughout the environment, and the brain needs movement. I guarantee for those of you who are here watching for the long length of time that we are on, which is a total of 90 minutes we're on. Those of you, even though you think you're sitting still, one of your body parts is moving, whether it's a hand, whether it's your foot, whether it's your knees, maybe you're rocking back and forth. That is your brain saying, I need movement. I can get lost very quickly in this environment. You need to help me. Now think of during COVID again, for many people became extremely sedentary. What also happened from that was extreme muscle loss. And muscles are one of the major receptors on the external part of the body for location in space, for proprioceptor sense to be able to function. Symptoms you may see in the early stages, short-term memory loss. Well, remember, I just said that's the very first loss you see. Difficulty finding words, behavior changes, loss of ADL skills or most recently learned skills, confusion over night and day, the sleep erratic, loss of interest in hobbies, events, or activities, slowing of movement. Even if you feel very secure in the diagnosis someone has had of Alzheimer's disease, never, ever assume that these losses are solely the responsibility caused by the plaquing and tangles, the disease process, because there can be other causes too, and we need to make sure that we treat and find out, and we make sure we, as much as possible, have a physical environment that helps maintain function, the feeling of comfort and safety, the capacity to be engaged in part of the physical environment and the social environment to stay engaged to others. And so it is essential that these are what we may see in the early stages, but we need to find a way that we can adapt the environment also for the caregiver as well, to help the caregiver. So let's talk about how. Well, symptoms in mid-stage, increased of the previous symptoms, increased difficulty understanding language, extreme disorientation to time and place. Literally don't know who they are or where they are. We're going to talk about things we can do in the physical environment in a few minutes. And I have a few visuals, never as many as I wanted. Typical for me, I had about 70 slides I had put together for this and knew I couldn't do it in a short period of time. And so I had to make tough decisions to eliminate some of the slides. Confusion and frustration. The frustration is not because of you. It may be the physical environment is too overwhelming when it wasn't in the past. It's the brain damage. And we can set up an environment to be supportive. Severe changes in personality. We do not appear who we were in the past. We're not behaving who we were in the past. Again, this is where it's important to have a baseline to know who the person has been, to know as much about their sensory reception, their sensory impairments, and their sensory processing. Seizures, if they had them, may have had them as a youth, may have been controlled, may begin again, or may have always had seizures, and they may increase in severity, or may never have had seizures, and now you may be seeing them. Later stages, we're looking at the remaining senses of taste, touch, and smell. So in the later stages, using these remaining senses to communicate with the individual and for sensory information activities, trying to keep the person engaged and part of the physical environment. I worked with an individual who had to spend most of the time sitting or laying in bed. could be moved, but very, very difficult. But by having light shows that the individual could and actually was still able to press a button and to change the light and be able to, this kept the person still engaged with the outside world, and that's what you want to do. Be ready to assist. Remember, I said a tactile sensation, touch is in both lobes of the brain. And so there's a likelihood that touch will still be something that is detected, processed by the brain, and being able to use as cues. So think about how you can help the person as long as the person is comfortable with the touch. And again, you need to know, especially if a person had tactile defensiveness early in life, and understand that skills will vary even more day to day and faster regression in the later stages. So here are the 7 senses. All of these work together: vision, auditory, gustatory or taste, smell, and taste and smell are extremely close together, and the processing of them very close together in the brain, and thought to be that they remain long after the ability of the brain to still interpret what the smells are. Catherine gave an example of someone not being able to interpret the smell of smoke as something that could be dangerous. And so the smell, the sense may be there, but the ability to process that and to make meaning out of it may no longer be there. Tactile or touch, proprioceptor and vestibular. The location in space is the proprioceptor, the location of where your body parts are. In the vestibular, which is located in the inner ear, and we'll see this a little bit in a minute, the head moving through space. We need to be able to discriminate, modulate, and integrate the senses. The brain does all that for you, absence disease process. And there's likelihood each of us and each person has a preferred sense for learning, taking in the information, the sensory information from the environment. Visual for me, along with experiential, visually being able to see something, and then also being able to go to that visual memory I talked about. That memory of being able to use that to be able to locate myself in space and be able to determine how I should function in that space. If that is disrupted, both with a visual impairment and then with brain damage, you can see how people cannot locate themselves in space. If you don't know where you are, for example, from the desk or table where your computer is sitting, you don't know how you can be able to turn on the webinar or maybe even respond to the computer. The computer now might be a frightening object rather than something that's giving you information. Every moment in this disease, because of disease process, is a novel moment. Every environment appears strange. This is why habits and routine, you need to know as much as possible about the person earlier in life and use that to set up the environment, physical, how activities people are meant to participate in. For example, if someone has always sat at the same dining room table in the evening for dinner, then if that is still working and the person is still comfortable and still able to eat and is not frightened to be there, then we do the same routine as possible. We also try to reduce the meaningless stimuli in the physical environment. For example, if we want to try to communicate and the person still understands verbally some simple directions, we don't want to have a loud radio going at the same time, listening to a rock channel or whatever it is. We want to look at what is the meaningful stimuli we need to maintain in the environment and how to reduce the other stimuli in the physical environment. Choices can be difficult, and so we eliminate the idea of choices and think about ways that they're meaningful, maybe one choice at a time. Keep furniture and objects in the same place, a strict routine. And I'm finding that people are well underestimating how the routine for people, habits for people have changed drastically since COVID. I'm called in often saying, well, they're refusing to go back to program. And these are people who have been diagnosed with Alzheimer's disease and now were at home for 2 years during the course of the disease. And now we're expecting them to go back to the program, and people don't understand why don't they want to go. Well, transportation is probably terrifying. And we've spent 2 years telling people it's dangerous to be with others. It's dangerous to be outside. We had to wear masks. We had to do extreme, not extreme, very meaningful infection control. But to help people understand, we made everything fearful as well. And so very slowly and carefully, especially with this disease, do you want to change the routine? That doesn't mean you give up and the person doesn't ever go outside the home, the residence, but that we do it slowly in a way that feels safe and comfortable. May no longer to be able to go on a bus or a large van and may have to be transported by car. Organizations need to try to make changes and adjustments and think about how they can help transport people and help people be able to adjust to go back to other activities outside the home. Vision is likely the sense most relied upon for sensory information for functioning and movement. Visual impairments in general increase with age. So before this disease, we want to know what visual impairments did someone have. The eyes are the major receptors of the visual sensory information. Eyes become less elastic, so they can't see colors in the same way. There may be cellular loss that no longer interprets colors, cannot see busy patterns anymore because of the loss of the elasticity in the eye. There also can be cellular damage in the eye, meaning there is less sensory information being sent to the brain to be processed in the first place. So the visual impairment means, and the nerve endings related to this are damaged as a result not of the disease, but because of other reasons, the same for why we have visual impairments, as well at the same time as we have extreme glare sensitivity. Simply too much light entering the eye, again, making it impossible for the information to be sent to the brain and making it more likely the person will be lost in space and time. A yellowing of lenses, development possibly of cataracts on the eyes with spots. And so those disease processes will cause nerve damage on the outside, not because of the disease, but the diseases of vision, diseases of the eye will do it. And it continues to happen throughout the course of the disease. Aging doesn't stop. Depth perception, color contrast, acuity, object identification, not being able to see people move, not being able, remember I said there's a memory, delayed recall to that visual stimulation. Don't know what it means. To know that you have to put your glasses on, you already know you have a visual impairment, you have to have a memory of what those glasses mean, what that object is, or a memory of how you put them on your face, and a memory that that's how you wore them. And so again, you see how all of these processes are disrupted, and what appears to be someone being stubborn and obstinate, maybe there's no memory to wearing glasses, and possibly the vision is so impaired that the glasses are no longer correcting the vision and impairment that was originally there. not being able to see what's the important object in the environment you want to use, lack of figure ground differentiation, not seeing size and shape, not having that visual memory anymore. So here we have size and shape, position of tables to be able to take your chair and be able to pull them up to the table may now be impossible because you can no longer interpret what size and shape means. You can no longer interpret depth because you're no longer getting the information into the brain to process and be able to determine how you can function, how you can use these objects. So we want to reduce visual clutter, organize visual clutter into specific places, clearly identified walking paths, and reduction in glare in the physical environment. I will have some pictures in a minute. Let me just go through quickly. Hair cells in the ears are broken down. They transmit the neurons of the brain. There are far fewer of them for many of us as we get older, and a high rate of hearing loss in older adults. By the time we get to 75, we're looking in 1 in 2.5 persons a significant hearing impairment. Hearing impairment is considered one of the risks for Alzheimer's disease. I wonder if it's a risk or if it's one of the symptoms, hearing loss, that makes assumptions that dementia is normal aging. Reduce background noise. Add as much soft material as possible. Increase lighting as we use multiple clues to function. Visual or physical cueing. We have an example with our wonderful interpreters today who are giving a visual cueing for people who may not be able to hear. Hopefully people who know how to use the information provided by the interpreters can use it far into this disease, but they will at some point also lose the capacity to be able to understand what the interpreters are telling us. They may have to wait longer to give a response, and it's essential that the caregiver is extremely aware of this and is present in the moment. Simple and short, one direction, a piece of information at a time, spoken at eye level. Smell and taste. We have different degrees of sensitivity, maybe too much or too little, and medications affect taste and smell drastically. Be aware of the smells in the environment. Also know those smells and tastes that people like earlier in life, what smells and tastes they hate. If I end up where I have the smell of onion all the time and I'm in a long-term care, I will be the worst, the least and worst patient and worst compliant patient you will ever know. We have memories from smells. Know the good memories because we can use those memories. A person may no longer say, that smells like mom's chocolate chip cookies, but may know that those smells have a relationship to eating and something good. Spitting out foods can be a combination of texture, taste, and smell. Try other foods. The places on the body where we have the sense the most receptors are the soles of the feet and the palms of the hand. And so you will see people who we think are tactile defensive or who are touching everything, maybe licking things, going back to infants. Infants lick things because of the cells that are on the tongue that give them information. It may not be the sensory information we want the infant to have, but the infant can't determine what's good and bad to do. The infant is getting sensory information and trying to learn from the physical environment. This is also what a person in middle and late stages may do within the physical environment. And so we need to think about ways how we keep the what they do this safe and something that is appropriate. And so this is how we set up environments to make sure that people don't ingest or lick dangerous objects. Tactile defensive, avoidance of baths. And Catherine talked about the feeling of pain in baths and showers. avoidance of dental care, responding with aggression to light touch, increased stress when close to people, pulling away and avoidance, or touching every object. I want to go on to, these are the places where the information comes in on proprioceptor. And this is vestibular in the brain. Let's look at maximizing location and function. Environmental cues such as visual pictures on the door. If you look at the pathway here, you can see this is a great example of contrasting colors in helping people be able to navigate in space. Think about how you can use this in living rooms, bedrooms, to bathrooms, hallways, making sure you're using contrasting colors to help people navigate through. If you look at this visual, you can see gray upon gray upon gray. Always use good contrasting colors and help develop pathways, and use good contrasting colors for those objects you want people to be able to still find and be able to use as much as possible. Know that location in space is lost. You can see how this white and all this is extreme glare. And you see all this, you want to look in your physical environments, take photographs that will help you see why people are having difficulty functioning, find ways you can help cue them. Assume the environment is always novel. Always have people sit in chairs with arms. You can see where this blue is a good contrast to the white. Even a darker blue would be a better contrast. If this was the person's favorite chair and they're still able to use this favorite chair, and it's still a strong enough contrast, then you encourage it, because this is personal space and you want people to have personal space. If the person can't, you can put a back over the back of this, because it may need to be, it's no longer contrasting enough for the person. And you may need to make a pathway for the person, a safe pathway for the person to still be able to use objects they like to use previously. See the world through new eyes, never assuming there is nothing you can do. So look at signage, clues that are meaningful, easy to understand, and posted where easily seen. Bathing, make sure they're warm rooms, accessibility, dressing in warm rooms, the clothing that people prefer. They're not taking their clothes off, as Catherine mentioned. They are probably in pain from the clothes they're wearing. One food at a time and contrasting. AD and sundowning understands the response to change of shift, transition times, and lack of light. It is an environmental issue. Increase full spectrum lighting, reduce stimuli and confusion, remove individuals from busy areas to quiet areas with good contrasting colors and feeling safe. Promote as an exercise. The brain needs to movement. Do not prevent movement. Create safe walking pathways, safe wandering spaces with opportunities for sitting, drinking. I would have loved, I eliminated a lot of visuals. I know I'm at the very end. Know the baseline, be flexible and balancing, flexible for changes over time. Create a toolkit including sensory information about the person and how you can set up a sensory-friendly, dementia-capable environment. Take photos of the environment, of the person. Take yourself outside and you can see more clearly the reality of each person. They're probably, success is a peaceful, happy moment. Make sure there's time for laughter and humor. Sleep and eating happens, and that we all take joy in the moment. And thanks as always to ONEgeneration, our funders and our special interpreters, who today's interpreters kind of last minute were called in, and we are just so appreciative for them coming in. Is there any reasonable question we can respond to? I mean, it can do in a reasonable time, not that your questions are reasonable.
Yeah, I think we can let those go for now. Someone did ask about a transcript. You'll get a link to the recording. of the session. And I think as Lori said earlier, it'll be posted on the One Caregiver resource website. And also will be sent to anyone who was registered for the workshop. So that'll go out within the next few days, probably early next week, given this is Thursday. There is the link to the post-test. I just put it into the chat box, so you should see it pop up in the chat box. Please do take the post-test. Remember, the first 50 people to complete both tests and get the highest scores, there are criteria here for this, will get a incentive. That is not for everyone. You have to complete both tests, be one of the first 50 people to complete them both, and get the highest scores out of the 50. So with that, does Lori have any last comments she would like to make?
I just want to thank everybody for your participation. The NTG, Kathy and Catherine, you have been the most amazing partners during this series. And all of our ASL interpreters, we could not have done any of this without you, and we're very, very grateful. So thank you.
Thanks, Lori. It's been a pleasure working with you, and we look forward to more activities as we move forward. Thank you. And with
Yeah,
that,
and thank you, and we're always available. So just our emails are here, but please contact Lori or ONEgeneration because they can always connect you to the NTG and to us as well. Thank you as well. Sorry.
So with
Catherine.
that, we will conclude our webinar. I will leave the screen up for another couple of minutes so that people can get the URL out of the chat box or the QR code here. But that does conclude our